Hello, everyone. So in this talk, I shall be talking about errors in pediatric fracture diagnosis. By errors, there can be two types of errors. Misdiagnosis, wherein the fracture is present, but the radiologist or treating clinician fails to pick up the fracture. Or misdiagnosis, which are certain radiological signs which are not actually fractures, but are misinterpreted by the clinician to be a fracture. So why do errors occur in pediatric X-rays? And as I assimilated the cases which I'm going to discuss in this talk, I realized that most of the errors that can be categorized under four categories. The first category of error is as simple as failure to acquire adequate or appropriate X-rays. Second is fracture occurring through radiolucent cartilage. Third is failure to identify normal variants in pediatric age group. And lastly, failure to acquire advanced imaging where needed. So in the subsequent talk, let's discuss each of these headings one by one, and I shall give you case examples under each of these headings. So case number one is a 4-year-old boy, history of fall from height with refusal to bear weight on the right lower limb, and this AP X-ray has been done. Now, if only this AP X-ray is available to you, on cursory look, you might dismiss this to be normal. However, when a lateral X-ray is obtained, it is very clear that this child has a fractured neck femur, Delbet type 1. And if you go back to the AP X-ray now, you will realize that there is slight fascial widening on the right side as compared to the left. So this is obviously a fracture which needs to be treated by close reduction and K-wire fixation, which was done. So the lesson that we learn from this case is, in any case, always obtain AP and lateral views. Two orthogonal views are must to make a diagnosis. Case number two, again, a young boy, history of fall on the outstretched hand, followed by trauma to the upper forearm and elbow. What can be seen in this X-ray is that there is a fracture of the olecranon. So this was treated as an undisplaced fracture of the olecranon with simple immobilization. However, 3 to 4 months later, the child follows up with a bony bump along the anterolateral aspect of the elbow. And now when an X-ray is repeated, what it reveals is this was actually a fractured olecranon with anterior dislocation of the radial head, which is a Monteggia variant known as the Hume's fracture. Now, if you go back to the original trauma X-ray and draw the radial line, it is very clear that the radiocapital alignment is disturbed even in that particular X-ray. However, because proper AP and lateral views were not obtained, this injury was missed at that point of time. This injury now needed a full reconstruction in the form of ulnar osteotomy and open reduction of the radial head, and the child went on to do well. So the lesson that we learn from this case is never compromise on X-ray quality. If you have received poor X-rays, make it a point to repeat the X-rays or make it a point to supervise the X-rays yourself. Another case example. Now, this is a 4-year-old girl, fracture of lateral condyle humerus. And this seems to be an undisplaced fracture, what we call as a Song type 1 fracture, and which can be easily treated with just a cast in situ. However, in lateral condyle fractures, it is known that in order to assess the displacement accurately, internal oblique radiographs are necessary. Therefore, an internal oblique X-ray was obtained in this particular case, and this showed that the displacement was much more than assessed on AP and lateral X-rays. So this was actually a Song type 3 fracture, which required a close reduction and K-wire pinning. The same applies to medial epicondyle fractures as well. In medial epicondyle fractures also, the fracture displacement is best assessed on the internal oblique views. Therefore, in special fractures, you have to be aware that additional special views are needed in order to assess the fracture displacement, and this can have a large bearing on your treatment protocol. Another example, now this is again an elbow trauma, and the child has some fixed flexion deformity of the elbow. He's unable to fully extend the elbow, and this was diagnosed to be a lateral condyle fracture. However, if you look carefully, this line, which is diagnosed to be a fracture, is actually an overlap of the capitulum on the distal humerus metaphysis. And this appearance is because the X-ray has been done in a flex position. Therefore, in such situation, you need to obtain two separate X-rays, one for visualizing the distal humerus and the other for visualizing the proximal radius ulna. And when this X-ray is done, it is clear that there is no fracture. Therefore, in the presence of associated deformities, always interpret your X-rays with caution, and you may need to do additional special views. So, under this category, we discuss the cases of inadequate or inappropriate X-rays, and what we learn is always obtain AP and lateral views. Don't compromise on your X-ray quality or X-ray views. Obtain special views in specific situations. So with this, we move to the second category of errors, and that is fracture through radiolucent cartilage. So we know that the pediatric skeleton is full of, a large proportion of the pediatric skeleton is radiolucent cartilage. And if your fracture passes through this cartilage, it won't be visible on the X-ray. So take this example, a history of fall and trauma to the wrist. And if you look very carefully, the distal radius epiphysis is slightly displaced, but because the fracture line is going entirely through the distal radius physis, it cannot be seen on the X-ray. So this fracture was missed on first instance, and the child followed up 2 weeks later with a malunited distal radius physeal injury. Therefore, always remember that Salter Harris type 1 fractures, if they're undisplaced, can be missed. And in such a scenario where there is a mismatch between the clinical findings of pain, swelling, and the X-ray findings, always suspect X-ray passing, the fracture passing through the physis. The amount of cartilage is especially high in younger age group, in children less than 3 or 4 years of age. And over here, the chances of missing the diagnosis if the fracture passes through cartilage is especially high. So here I will discuss 3 cases of neonatal injuries where the fracture line passes entirely through the cartilage. So this is an elbow trauma, a child born after a difficult labor, and there is decreased movements and swelling of the right elbow. And after looking at the X-ray, it is very easy to label this as a dislocation of the elbow. But remember that traumatic dislocation of the elbow is almost unheard of in the neonatal age group. So this is actually a distal humerus transphyseal separation. And when a follow-up X-ray is done after 2 weeks, you can see that the fracture is healed. There is callus around. And after some time, the fracture remodels with good consolidation. Another example, this time it is the knee. Again, a difficult labor followed by decreased movements and swelling around the knee joint. And what you can see over here, there is a bony fleck along the anterior aspect of the distal femur. Now, if you remember, the distal femur epiphysis is one of the only epiphysis in the body which ossifies at growth. Therefore, this actually is not just a small bony fleck, but it is the entire distal radius humerus epiphysis which has displaced. And so this is a distal femur physeal fracture. And if you do follow-up X-rays, you realize that this fracture then heals, it remodels, and it consolidates. So because the fracture line initially was passing through the cartilage, it was not seen. Another example now, this time the shoulder. And you can see that the medial clear space in the right shoulder is definitely more than on the left. And this was diagnosed to be a case of shoulder dislocation. However, this is not a shoulder dislocation. This is a proximal humerus physeal fracture. And if a follow-up X-ray is done after 2 weeks, you can see callus around the proximal humerus metaphysis. So remember that in young children on plain X-rays, you can see the fracture line if it goes through the bone. But if it goes through the cartilage, it will not be visible on plain X-rays. And in such cases, you have to imagine the fracture line going through the cartilage and have a very high index of suspicion. With this, we move to the third category of errors, and that is failure to identify normal variants. So the pediatric skeleton is replete with secondary ossification centers as well as accessory ossicles, and each of these can be misdiagnosed as a fracture if you are not aware of their presence. So let's take a few examples. One of the common secondary ossification center which is misdiagnosed to be a fracture is the one at the base of the fifth metatarsal. So how do you differentiate the secondary ossification center from fracture? So if you look at it, in a secondary ossification center, the radiolucent line is always longitudinal. So when the radiolucent line is longitudinal, it is a secondary ossification center. On the other hand, if your radiolucent line is transverse, it indicates a fracture. Another example, now this is a curious variant. It is called bipartite patella. And as you can see, the superolateral corner of the patella appears separate from the main body of the patella. So how do you differentiate this from a fracture? For number one, look at the margins. The margins are absolutely smooth. They are not jagged like in a fracture. If you do an X-ray of the contralateral side, you will most commonly see normal variants on both sides. And thirdly, the site. The site on the superolateral aspect of the patella is an extremely rare site for a fracture. So these points can help you to differentiate a bipartite patella from a fracture. Then look at the proximal humerus. Now this line, it is very easy to misdiagnose it as a fracture. But if you understand the anatomy of the proximal humerus, the proximal humerus physis is a spiral physis, extends from the superior anterior to posterior inferior. And therefore, this radiolucent line is nothing but the physis, and it is visible so because of the spiral nature of the physis. And you have to be aware of this in order to avoid misdiagnosing this as a fracture. In the distal tibia, the Poland's hump is an elevation near the medial end of the distal tibia physis, and this can be misdiagnosed to be a fracture. Also, an os subtibial, which is an accessory ossicle at the tip of the medial malleolus, or an os subfibular, which is an accessory ossicle at the tip of the lateral malleolus. These can be misdiagnosed as fractures. There are some secondary ossification centers which ossify by multiple smaller nuclei, for example, the olecranon or the radial head or the trochlea, and these can be misdiagnosed to be fractures. So you have to be aware of these normal variants in order to avoid making these errors. So before diagnosing a fracture, always think whether this is really a fracture or this is a normal variant. Finally, coming to the last category of errors, and that is failure to acquire advanced imaging in special situations. So I'm giving you a case example from Peter Waters' paper on trash elbow lesions. So this is a 4-year-old boy, history of fallen outstretched hand, severe swelling, and the X-ray looks completely normal. So in this case, since the pain and swelling was out of proportion, an MRI was obtained, and what the MRI showed is that the radial head was fractured and completely displaced. But because the radial head was not ossified, it was not visualized on the plain X-ray, and MRI was needed to diagnose this. So these types of lesions are especially common around the elbow because there is a lot of cartilage around the elbow, and it has been given an acronym, that is the TRASH. The TRASH stands for the radiographic appearance seemed harmless, and there is a list of injuries which come under this category of injuries. We have described one category of TRASH lesions, that is a chondral stress fracture of the capitulum. So these were the case report of 2 adolescents who presented about 4 to 5 months following trauma with stiff elbow. The X-ray was not really clear as to what was going on over there. However, when we did an MRI, what we realized is that a portion of the cartilage of the capitulum, it was sheared off, and this portion was lying along the posterior aspect of the elbow. So this is a chondral shear fracture of the capitulum. Now, this was almost a 4 to 5 month old injury. So there was no question of putting this fragment back into place. We had to do a loose body excision along with microfracture of the exposed subchondral bone of the capitulum. Now, before you order advanced imaging, you have to understand why you are ordering the imaging. So if you want to see the cartilage, then remember that the investigations which can visualize cartilage are number 1, MRI, number 2, USG, and number 3, arthrogram. On the other hand, X-ray and CT scan cannot visualize cartilage. So if you are suspecting injury through cartilage, an X-ray or CT scan should not be ordered. Instead, you can order either for MRI or USG or arthrogram. To end my talk, last case I'm showing to show the utility of arthrogram intraoperatively. So this was a child who presented with a radial neck fracture. As you can see over here, this is the radial neck fracture. However, because the radial head had not yet ossified, it is not clear as to what is the amount of displacement, and also you cannot assess your post reduction accuracy. And therefore, in these cases, that arthrogram is extremely useful. So an arthrogram was performed in this case. And after the arthrogram, you can now clearly see the outlines of the radial head. You can see that the radial head is severely angulated and displaced. And so a close reduction was performed. And after close reduction, now the radial head has sat back in place. So an arthrogram is a very useful intraoperative investigation to visualize non-ossified cartilage. So this was a post-op X-ray, and the child went on to do very well. So in special situations, acquired advanced imaging, and if cartilage injury is suspected, MRI or USG or arthrogram is the investigation of choice. So to conclude, don't compromise on X-ray quality. Think of fracture through cartilaginous component. Be aware of normal variants, and in special situations, obtain advanced imaging. Thank you.